Fertilization in humans is internal. It takes place inside the body of the female. Semen, which contains the sperms, is introduced into the female genital tract during the act of copulation. The deposition of sperms in the vagina is called insemination. Human sperms are motile and rapidly swim towards the ovum, lying in the fallopian tube. The sperms pass the cervix, enter the uterus, and finally reach the ampullary isthmic junction of the fallopian tube. This is the site where the ovum lies and fertilization takes place. When a sperm meets the ovum is in the secondary oocyte stage. It has not yet completed its second meiotic division. The fusion of sperm and ovum is called fertilization. For fertilization to take place, the sperms must be released in the vagina during the period that the egg is alive, that is, within 24 hours after ovulation. The sperm has to pass through the corona radiata and the zona pellucida to reach the plasma membrane of the ovum. When it reaches the zona pellucida, the acrosome releases its contents of lytic enzymes. These enzymes dissolve the zona pellucida. The sperm plasma membrane then fuses with the egg plasma membrane. This fusion triggers the secondary oocyte to complete its second meiotic division. The second meiotic division is also unequal and leads to the formation of a second polar body and a haploid ovum. The nucleus of the ovum is now called the female pronucleus. The cortical granules present below the egg plasma membrane release enzymes which harden the zona pellucida and block further entry of sperms. The sperm nucleus now enters the cytoplasm of the ovum. The sperm nucleus is now termed the male pronucleus. The male and female pronuclei come together and fuse. The male and female chromosomes mix. This event is called karyogamy or amphimixis. Fertilization is thus completed. The fertilized ovum is called the zygote. Identical twins are formed when the zygote splits into two. Each split portion then develops into a complete new individual, and both are exactly identical to each other. On the other hand, non-identical or fraternal twins are formed when two separate eggs develop in the mother's body, and they get fertilized by two separate sperms.
Hello, I'm Dr. Lauren Hyman, and welcome to Scooch Down, where you can talk to your gynecologist like you talk to your friends. So you've been trying to get pregnant. It's been a year. Seems like everyone you know is pregnant, but you're not pregnant yet. What does a basic infertility workup consist of? Well, what we want to find out is if there is any reason why you haven't conceived yet. The vast majority of time, basic infertility workups show nothing wrong with the woman and nothing wrong with the man. But you want to rule these things out so that you can go on, and if there is some type of a situation, fix it. So what are we looking for with a basic infertility workup? We want to make sure the woman is ovulating, we want to make sure the man is making healthy sperm, and we want to make sure there's no reason they're not getting together. Let's start with the woman first. For the woman, it's mostly blood tests. On day 3 of the cycle, we want to do a blood test to look at hormones. We want to look at the estrogen, the menopause or FSH hormone. Sometimes we'll look at an anti-Müllerian hormone that can help us look a little bit more closely at the quality of the eggs left in a woman's ovary. We want to look at the thyroid, prolactin level. Sometimes we'll even look at the glucose and the insulin levels. All these things are things that can affect metabolism, affect hormones, and cause the woman to not be ovulating regularly. Let's look at the man. Just as often, it's the man's side that determines why a woman is not getting pregnant. It's a simple semen analysis. We like the semen analysis to be collected 3 to 5 days after the last ejaculate so we can get a really good specimen. We want it to be delivered to the lab as quickly as possible. And what does the lab look for? The lab makes sure that the sperm are healthy, that there's a head and a tail, the number of sperm, the motility, and that they're moving forward and how fast they're moving. Once we know that the sperm are good, once we know that the woman's ovulating, are the sperm and egg getting together? There's a procedure called a hysterosalpingogram that can help us determine that. HSG, hysterosalpingogram. Essentially, it's a tubal dye study. A small catheter is inserted into the woman's cervix and dye is pushed up, filling the cervix, the uterus, and out the tubes. Then an x-ray is taken. We can see if there's any blockage in the tubes, if there's any defect in the uterus. Possibly both tubes are blocked, and that's why the woman's not getting pregnant. There's another test called a postcoital test. You know that egg white discharge people get mid-cycle? Well, that is to help trap the sperm and make it more likely that that sperm is going to get up there and meet that egg. With a postcoital test, the woman and man are asked to have sex and then come into the office afterwards. The doctor with a pipette takes a little bit of the cervical mucus out of the cervix, puts it onto a slide, makes sure it is nice and long. That's called spinbarkite, and there's good stretch. And then with that slide, looks under the microscope to make sure that the sperm are active, healthy, and swimming around after having come into contact with the woman's cervical mucus. It's a test for the cervical mucus and to make sure there's nothing going on between the man and the woman once things are coming together. So once we've made sure that the woman is ovulating, the man's sperm is healthy, and there's no reason that the two of them shouldn't be meeting, we can go on to next steps as far as helping the woman conceive. This has been a discussion about a basic infertility workup. Thanks for tuning in to Scooch Down. I'm Dr. Lauren Hyman. I'll see you next time.
IUI cycles used to be the principle, the mainstay of infertility treatment, both for female and male infertility. I'm old enough to remember the days when over 90% of our cycle activity at CHR were IUI cycles, and IVF cycles represented less than 10%. But in those days, pregnancy rates between IUI cycles and IVF cycles were very similar. And so in those days, it made a lot of sense to start with IUI cycles. And if they did not work, or if there was a reason not to use them, like if a woman has clogged tubes, it doesn't make sense to do an IUI because egg and sperm will never meet, then you went to IVF. But things have changed over almost 35 years of IVF. In the early days, IVF cycles gave single-digit pregnancy rates. Today, IVF cycles are very, very successful in their pregnancy rates. Obviously, things depend on age of patients, on other circumstances. And it may still make sense in a young woman in her 20s who has open tubes to try a few IUI cycles, particularly if the problem is that the male has a relatively low sperm count, so bringing the sperm closer to the egg, to the fallopian tubes through an IUI may allow patients to get pregnant quickly, even with IUI. But in general, the cost effectiveness curve and the clinical effectiveness consideration has dramatically changed, because today on the average, an IVF cycle will give you at least 3 times the pregnancy chance of an IUI cycle. And that means that per treatment time unit, which is usually 1 menstrual cycle, the pregnancy chance is 3 times as high for an IVF than for an IUI. Now, most patients who come to a fertility center for treatment have already tried a long time to get pregnant and otherwise wouldn't be in the fertility center. And they usually are anxious to get pregnant relatively quickly. So why expose them to a second best treatment that will take them 3 times as long?
The success rate for IUIs will stubbornly hover around the 8%, whereas for the IVF will be in the 50%. One way of trying to understand that is to ask yourself, our success would mean 100%. So how many times does 8% fit into 100? That's about 15 times. So it would mean that potentially you could need 15 IUI cycles to get to that pregnancy. I hope you get pregnant on the very first cycle, and some patients achieve that, about 8% of patients. Whereas with the IVF at 50-55% success rate, your probability of achieving that pregnancy and hopefully delivering would be, you can fit 1 to 2 IVF cycles into 100. So that would mean that within 1 to 2 cycles, you could potentially achieve that pregnancy. There are situations where IUIs can be very effective. For example, if there is a single woman or a woman in a homosexual relationship who have completely normal, regular periods and all of the objective measurements of their fertility are normal, and all they need is what's missing, sperm. The use of donor sperm can be very effective because you are just replacing what is missing. Okay. Sometimes there are patients, for example, that have had a procedure in their cervix, and again, they have a completely normal fertility profile, except for that opening of the womb that has been narrowed by the surgical procedure, whether it is because of congenital birth or because of related to an abnormal pap smear and cervical dysplasia, then bypassing that cervix with intrauterine insemination as an initial approach makes definitely a lot of sense. But on the other hand, if you have patients that have moderate to severe abnormalities in the sperm, or individuals that have one tube that is blocked and the other is open, or women that are over the age of 38, 39, the approach of intrauterine insemination very stubbornly would remain at the 5 to 8% per cycle. And I look at my patients and I say, I hope they get pregnant the first cycle. And many say, it's me, the one that is going to get pregnant the first cycle. But unfortunately, and I hate to repeat it, that probability of success, study after study, center after center, shows that that figure of 8% remains very stubbornly there. So the in vitro fertilization would be a much better approach.